All right, everyone. Thanks for attending. We're going to kick this off now. I'm really excited and lucky to introduce one of my hospitalist colleagues for today's talk. So, Nathaniel Golden Meadow, which I just actually learned is actually his name, Nathaniel Golden Meadow. MD, MPH is a physician of internal medicine at the University of Chicago Medical Center, where he has practiced as a hospitalist since 2020. His medical career bridges clinical care, ethics, and public health, reflecting a commitment to patient-centered medicine and systemic well-being. A graduate of the University of Illinois College of Medicine and School of Public Health, Dr. Meadow was a member of the Urban Medicine Program and a fellow at the MacLean Center for Clinical Medical Ethics, where he explored the intersection of ethics, equity, and care delivery. Dr. Meadow's early research in cognitive psychology and neuroscience focused on the ways humans learn, think, and perceive, publishing award-winning work on spatial cognition and memory. This foundation in mind-body connection has shaped his clinical philosophy and his evolving interest in psychedelic-assisted therapy, for which he completed a certificate program at the California Institute of Integral Studies in the spring of 2025. Drawing from his background in internal medicine, public health, and psychology, Dr. Meadow approaches psychedelic-assisted therapy as a field with profound potential to heal trauma, depression, and existential distress, while demanding careful stewardship and scientific rigor. As a lifelong advocate for health equity, Dr. Meadow has served as a founding board member of Men for Choice and has volunteered across Chicago's underserved communities. Outside of medicine, Dr. Meadow is a husband, father, and card game creator who believes that healing, like learning, is as much about curiosity and connection as it is about science. His talk today is called Dying is Hard. Could Psilocybin Help?
All right, we did it. Okay. Can everybody hear me in the back? Or this is a pretty small room. Thank you for coming, everyone. Thank you so much from the MacLean Center for inviting me to speak. All right, so here we're going to continue this lecture series on death, dying, and beyond. Today we'll be discussing the dying part. I think, let's dive right in. So I don't want to die. I think everybody has said this at some point. It's a fair thing to say. I think the dying process brings about some existential distress, anxiety. This is reasonable. This is kind of why we want to be a part of this community. This is kind of, we like our friends, we like our family, we want to stick around. And so when these things might be taken away, it's hard. And it's okay that it's hard. So everyone dies though. So how do we face that? We don't necessarily do it well. I think, thank you to this lecture series for at least kind of moving the ball forward in regards to having these conversations. I think there are some parts of kind of the dying process that we do relatively well in our culture though, right? I mean, like we write a will kind of once we have kids, we kind of get our finances in order, your estate in order, right? These are things that are built into our cultural practice that if you didn't do them, there would be kind of an expectation of like, well, why not? And so I think the question is there a way that we could make the reflection part of dying actually a part of our culture as well? So how are we dying? So this is from data from 2023, pulled this from the CDC. So heart disease is still the largest killer in America as of 2023, but cancer is kind of right behind it. Cancer, of course, is a big deal here on University of Chicago's campus, the new Cancer Center coming up in 2027. Of course, we already treat many people with cancer. And that is where we're going to kind of spend the lion's share of our conversation today, is kind of end-of-life anxiety with cancer. So what do we do now for patients who have cancer? The gold standard of what we do is palliative care. right? And this is now just part of what we do. This was a growing field. It's now just kind of part of it. It's embedded. My understanding is anybody who is treated for cancer at the University of Chicago has a palliative care team that is a part of their care. And that is great. It kind of brings in a little bit of this reflection. It forces people to have these conversations with themselves, hopefully with their friends, family, and loved ones. There's also things that palliative care docs can do in addition to the conversations, right? There's medications, SSRIs, anxiolytics, and then of course pain control, right? Cancer can be actually very, very painful. And so opioids are a mainstay should it come to that. I think there's also support groups, online support groups, in-person support groups. Sometimes information there can go off the rails, but I think in general, it's a good thing to have a support group of people who have a common diagnosis, of family members, right, who are sharing this trauma and this pain because a loved one is diagnosed. So that's kind of what we have as far as our main therapeutics now. And so the question is, could we add to that armamentarium for ways to help people? So could psilocybin help? I think before we dive directly into psilocybin, let's talk about the current psychedelic landscape in Western medicine. I think there's three main medicines that are being used, or at least they're kind of the main ones that you think about when you have this conversation right now for Western medicine. So the first would be ketamine, MDMA, also known as ecstasy, and then psilocybin, also known as magic mushroom. So let's take them in order. Ketamine. So ketamine is an NMDA antagonist, not for this talk. So the route of administration, you can do it in multiple different ways. There's like these lozenges that you can kind of put in. It's like buccal absorption. Those are kind of cool. You can actually have a conversation while using that route of administration for ketamine. There's intranasal. You can think Spravato is the most famous example of that. And then there's IV. That you really should have kind of an anesthesiologist, or at least somebody who knows what they're doing. Because of course, ketamine's therapeutic window is narrow, and so it can of course be dangerous. The length of experience is about 2 hours. You can vary that if you're doing it IV. And then the frequency of experience. So kind of the way these are set up is often between 4 and 6 experiences. And so you'll have a practitioner who will be with you to prep, kind of get you ready for what's going to happen. You'll have the experience, and then you debrief or integrate. So integration is kind of the terminology that people are using as far as what happened, how do we kind of download this, how do we debrief this. In the world of ketamine, they actually are doing it relatively frequently. So it's almost 2 to 3 times a week for a certain number of weeks. It's very individualized though. It doesn't, there's not like a real prescription for that. Part of the reason it's very individualized is because the offerings for it are mostly private clinics. So rarely is insurance going to be a part of this. So access is challenging. These are very expensive, especially if you're doing it IV monitoring, right? I mean, you're paying for an anesthesiologist's time. So this is a bit of a challenge in that regard. And then indications for ketamine, I think depression and chronic pain are kind of the two that everyone would be like, yes, that makes sense, move forward. MDMA or ecstasy. So the pharmacokinetics of MDMA are serotonin, norepinephrine, and dopamine. Just want to highlight that dopamine is a part of this because anything that uses dopamine as part of its mechanism of action is, of course, potentially addictive, right? And so not that it necessarily would force you to be addicted to it, but it's something that as we discuss novel therapeutics, we need to at least recognize potential for addiction. For MDMA, the route of administration is a pill. The experience is also about 4 to 6 hours. And so the frequency of experience for this one has traditionally been about 2 sessions and then kind of reassess. And when I say traditionally, I really am using the MAPS protocol. MAPS is a multiple disciplinary association for psychedelic studies. So they did kind of the largest trial so far with MDMA, and they did it for treatment of post-traumatic stress disorder. They actually went through 2 phase 3 trials. They made it in front of the FDA, and unfortunately, or fortunately, the FDA kind of had their determination. They deferred. They did not approve MAPS, or I guess now Lycos, because they have a for-profit spinoff. They did not approve MDMA for treatment of post-traumatic stress disorder at that time. There were, I'm sure, many, many reasons why. We can talk about them at a different time. But at this time, technically, there's no indication for MDMA because it's not FDA approved. But PTSD, and then some people say couples therapy, but mostly PTSD, I think, would be the potential use for it should it become available down the line. And now psilocybin. So psilocybin, magic mushrooms. The pharmacokinetics are serotonin and just serotonin. So the psilocybin is kind of part of the serotonergic psychedelic family. And so the other members of that family would be LSD, ayahuasca, DMT, which is the active ingredient in ayahuasca, and then ibogaine. These are just kind of terms, so now you've heard them. But basically, the idea is it is a serotonergic mechanism of action. It kind of floods the synapses with serotonin. It's different from an SSRI in the sense of SSRI is kind of a little bit of an adjustment every day. This is an experience where you're flooding the synapses with serotonin. You have the experience, and then the expectation is you're not going to use it again soon, right? So the frequency of experience for this is normally about 1 to 2 sessions, and then you reassess the need for it. And so I think it's kind of important to highlight that when we think about, again, novel therapy, does this become addictive? Technically, there's no like, it's not going to become addictive because it's just serotonin, but anything can be, psychologically, you can become dependent upon it. And so we just need to think about these things and just be cognizant of them as we move forward. Length of experience for this is also about 4 to 6 hours. And so what is the availability of psilocybin right now in America? Oregon, Colorado, and now New Mexico. So in Oregon, I guess we'll kind of take them in turn later in the talk, but basically these are state legislative legalization. This is not via the FDA, but this is kind of open for use due to states passing laws for it. Indications for psilocybin, end-of-life anxiety is the one that we're going to talk about a lot today. And then depression, and then I think substance use disorder is a potentially promising field should this become a part of the landscape of medicines that we have to use to help. So let's dive in. So the first study we're going to talk about for psilocybin and end-of-life anxiety was done by Roland Griffiths and his team at Johns Hopkins. I think Dr. Griffiths is probably one of the better renowned researchers in the psychedelic space. He took on the monumental task of doing a randomized, double-blind controlled trial with psilocybin, right? You can imagine the challenges that would be. Did you have a trip with magic mushrooms? Did you not? And it's kind of hard to blind that, right? And that said, this is Western America, this is Western medicine. We must have a randomized controlled trial. Otherwise, we will never allow it to potentially touch a patient. And there's a lot of good reasons for that. And so thank you to Dr. Griffiths and his team, and many others have done it as well, but for kind of really spearheading this. So what did they do? This was for patients who had cancer, kind of a serious diagnosis of cancer. I guess all cancer diagnoses are serious, but a potentially life-threatening diagnosis of cancer. And then patients who had depression or anxiety coming in. And by that, I mean they were rated, they were tested on these rubrics, depression rubric, anxiety rubric, and they were high on it already. And so they were eligible to be part of the study. Ended up with 56 and then 51 that actually completed the study, cancer patients. Oh, apologies. Formatting is terrible. So I guess I'll just kind of tell you what happened then. So for basically patients were randomized, and then it was a crossover format. And so they were randomized, then they got either low dose, that's this kind of 1 to 3 mgs per 70 kilograms. So low dose, basically a subclinical, subtherapeutic, well, a subclinical dose. You would not notice that you had received this, and that was used as placebo. And then a high dose of 22 to 30 mgs per kg. And this is like 4 to 6 hours of we're having a real psychedelic experience here. Like you're gonna feel this type of thing, which again, challenging for the blinding, but that was the mechanism of this. And then a crossover format. So then for the second session, after 5 weeks, those who got low dose got high, those who had high dose got low. Just so that way going in, everybody knew that they would have a high dose psychedelic experience as a part of being a part of this study. And then the follow-up, which is stuck in the middle here, is 6 months, right? And so there was a real test of durability of the effects of this study, which I think is pretty cool. We'll stay on this slide a little bit longer, even though the format is sad, because I want to talk about the psychosocial support that went into it as well, right? So there were, on average, about 2 sessions prior to the psychedelic experience, one post, kind of as a quick debrief, another prior to the second experience, and then 2 after that, prior to the 6-month follow-up. So on average, about 6 sessions per subject or patient, in addition to the psychedelic experience themselves. So what happens during this experience? So during this experience, it is the patient this is the experiment, so it's all kind of a controlled setting, indoors, but like a lamp as far as lighting, not the sterile things that we have in our hospital rooms, a comfortable couch, a rug, just like the idea that this is more of a living room than it is a hospital room. There was the patient, and then there was 2 monitors at all times as a part of these experiments. The monitors were there for support. There was not like a guide of like, here's what you should be doing and go this, that, and the other. It's none of that. They were there to hold space, to keep a safe container, to reassure this person that if something were to happen, we got you, it's okay, you're safe. And then if they did kind of pop up and they wanted to engage with somebody, then they would kind of try and invite them to go back inward. Because the point of this experience is to go inward and see what comes up and see kind of where the medicine takes you and follow it. There's like this mantra as a part of a monitor that's in and through that was popularized by Bill Richards. The idea that what you're seeing in front of you is there for a reason, and you got to go into it and you got to go through it if you're going to heal. Okay, this is not magic, it's still medicine, and if you don't engage with it, it won't help. But if you do, it has the potential to help. So kind of the classic scene is like, if you see a dragon, walk into the mouth of that dragon. That is the idea, that you're going to have to go in and through. So these monitors were just there kind of as a support. So what did they look at? They looked at primary outcomes. So primary outcomes were depression and anxiety, like we talked about before. So there was the grid ham and the ham A. These are the rubrics that they used, or these are the rubrics of the depression and anxiety scores. Necessarily, of course, these people were high on it, right? That's how they got into the study. And so let's look at what happened. So we see that, again, for both depression and anxiety, we start with at baseline high scores. High score here means that you are having symptoms of depression, you're having symptoms of anxiety. And necessarily so, because otherwise they wouldn't have been in the study. And then we see a pretty remarkable improvement. Right, so the red line is those who got the high dose first. The blue line are those that got the low dose first. So after the first session, we see a really significant statistical improvement in these depression and anxiety scoring, which is cool, right? I mean, that is relatively uncommon when we treat these things. We do our best, but a lot of people have depression, have anxiety. We do our best. They still have depression. They still have anxiety. I think it's also worth noting that you look at that blue line, there was improvement there as well, still statistically significantly different than the high dose first. But like, look at that blue dot, right? That is down. That is an improvement. I think that speaks to just the power of the body, that when we start to feel like we can heal, we do a little bit, right? You call that placebo, call it whatever you want, call it the psychosocial support of being a part of a study, call it just the belief that you're telling your friends and your family that I'm a part of this, I'm going to try. I don't care what you call it. The fact that it exists and it's helping people, that's, I think, what really matters to me. And of course, it's nice that it's statistically significantly different than the high dose first. So that way you can say the psilocybin was also genuinely, or at least statistically, we know that it was having an effect. Then we look at post 2. So that's after those are the low dose first had their high dose session, and they joined their colleagues down in this low scores of depression and anxiety rubrics, which is pretty amazing. And then you look at the 6-month follow-up and it stayed, right? This is durable. And this is, again, just the one psilocybin experience. Like, so 2 experiences, and so whether or not you feel just kind of being with yourself for 4 to 6 hours and thinking about yourself is beneficial, probably is, probably also very hard, but really just one psilocybin experience, and 6 months later, you're still seeing beneficial effects. A secondary outcome that the Griffiths team looked at, which I think is really wonderful, is they asked community observers, so by this I mean family members, friends, colleagues, to also rate the subject on, or the patient on, how they're doing. So they use a questionnaire. This is kind of a positive number, so the higher the number, the better off that you're doing, better in the sense of, they asked about these 13 items: forgiveness of self, forgiveness of others, self-confidence, positive emotions, kind of things of like well-being, right? And they asked these people, how is this person doing? They asked these friends and family members, how is this person doing? We see there was a baseline score, and then after post-session 2, so that means that all of these people had received the high dose experience by them. There was a statistically significant improvement in how others viewed this patient and how others felt this patient was doing. And 6 months later, it was still durable. And I think it's one of those things that maybe kind of can also, I don't know if you want to call it placebo, like the idea that this bias of, I feel like I need to be doing better because I've put in so much effort into this, I think is a little attenuated by, well, these are how other people view how these people are doing, and they thought they were doing better too. So now, rather than just kind of listing a ton of studies, let's kind of look at a meta-analysis about psilocybin and end of life. So there's a meta-analysis that was done by you et al. This was published in 2021. This looked at psilocybin, end-of-life anxiety symptoms. So with any meta-analysis, of course, the most important thing is inclusion criteria. So what they did here is peer-reviewed articles only. These patients also had to have a life-threatening condition, mostly cancer, also HIV was included. And then they included both controlled studies, so treatment compared with placebo, but then also an uncontrolled study, so an open label single arm. And then they were just written in English, so that way that was helpful for the for you et al. So non-clinical trials though, so case reports, case series, those were excluded. Here's the actual process, just because again, meta-analysis, like this process is vitally important for anyone who's done one of these. You understand how much work goes into it. I did one when I was kind of early in my training. It's a remarkable amount of work, and so I just want to make sure that kind of we all walk through it together. So, you know, they looked at kind of all the different online databases to find this, like InfoCentral, Medline, Embase, all of these things. They go through, you sift through, get rid of duplicates, sift through, get rid of ones by title and abstract, and then you read all these full text and decide whether or not they should be part of the study. So it's just a lot of work. Here, we ended up with 5 included studies. And I think it's important to recognize here that that's a small n. When we are in this space, we're dealing with small n's. And I'm not saying that it's not true, the findings that we're seeing, the results that we're seeing, but it just has to be recognized. The n is small, and so we need to be cautious as we move forward with it. Think about generalizability, think about kind of how treatments might need to be adjusted as they kind of get outside of the clinical setting. So these were the 5 studies that were included. You see the second one is Griffiths et al. That's what we just walked through. And then the others were also kind of double-blind randomized controlled trials or a long-term follow-up after a randomized controlled trial, and then the open label single-arm study. Again, things to highlight. The diagnoses, cancer, and HIV. The sample size, right? The sample sizes are small. Again, it's not saying it's nothing exists, it's just saying we have to recognize it. And then the dosing. These were all single dose. Okay, so just the idea that this is not a new daily pill. This is a different way to potentially treat these symptoms or even disease. And then as far as the kind of things that we were after, again, end-of-life anxiety was the main diagnosis. So what do we find? So this is state anxiety, and this is as defined by the authors, a transitory emotion characterized by heightened autonomic nervous system activity and consciously perceived feelings of tension, dread, and apprehension. So what do I feel when I read that? kind of this idea of like something big happens and you're like, ah, right? Like the kind of the fight or flight, the anxious response to something that's like in the moment. All right, and what we see here is that kind of 1 day post-psilocybin, 1 month post-psilocybin, you get reduced anxiety in your response to these events. And just want to highlight that while there is kind of 3 on top and 3 on bottom, it's not actually necessarily the same because not all the studies took their dependent variables at the same time. So, both Grobe and Ross et al., they took a dependent variable 1 day and 1 month, but Griffiths only took a post at 1 month. So just the idea, I just want to kind of highlight that what you're seeing here is generally, we're seeing a reduction in anxiety and state anxiety kind of at relatively quick follow-up. Moving further out, the authors also looked at what they call trait anxieties. This is a general tendency to respond with anxiety to perceived threats in the environment and is a relatively stable characteristic of an individual. So this is more, how do you respond to things? Are you an anxious person? Do things like small things kind of like really kind of get you revved up? And what they found here is that, mostly across the board, kind of in all 5 studies they looked at, there was, again, a reduction in anxiety that was durable, 6 months or even longer out. So I think now we should also discuss like indigenous use of psilocybin, right? So this is a novel therapy here in Western medicine. This is not a novel medicine. Indigenous people have been using this medicine for a long time, hundreds, if not thousands of years, right? This is a naturally growing mushroom, mostly kind of in central Mexican Valley and then spread through kind of Central America beyond there. I include this. So this is a excerpt from one of like the friars that were part of the conquistadors that came kind of after the Columbus, or after Westerners came to Central America. So I feel a little bad, like using a conquistador person's lens to describe indigenous use. But these are the written, these are kind of the written documents that we have, and so these are what we have to use. And I only include this kind of paragraph to, highlight that we're talking about the same thing, right? As like they describe the experiences of what people have, this is what happens, right? This is what happens when you go on a mushroom trip. And so I just want to highlight that this has been used for a long time. It's novel to us, but it's not necessarily novel. One other part, just kind of this idea moving further, there's, certainly there's evidence that mushrooms and its cultural use was spread, again, from the Mexican Valley through Central America, that Mayans used, that they consumed Psilocybe cubensis, and Aztecs called it the Teonanacatl, fungus of the gods or flesh of the gods. And again, I don't know if they were using this for like end-of-life anxiety, right? But I just mean to say that this was kind of a cultural use, traditionally a religious use, is kind of the understanding. Just the idea that we just have to pay homage to those that have been using this before. Otherwise, this medicine would not be on our radar today to potentially help people. So what is happening now in America? So there's current legal use of psilocybin in Oregon. So in Oregon, the psilocybin centers, they open their doors in the summer of 2023. You don't need a diagnosis to go. You just need to be 21 years or older, and you can have a psilocybin experience. It is expensive and not covered by insurance, so access there is, again, a challenge. But people are using it. So starting in 2025, Oregon Health Services had to releases the numbers for how many people have actually been doing it. And so you see in the first quarter, 1,500 people took advantage of this. And so it is being used. As I talk to my colleagues that work in Portland, like the sky hasn't fallen, things haven't gone off the rails. Like this is available for use, and it seems to be kind of part of the culture, at least growing itself into the culture. Colorado is similar in that they legalized in 2023. You have to be, again, 21 years or older, but don't necessarily need a diagnosis. And then in June of 2025 was the first, I guess, client or individual that was used that had a regulated psilocybin session. And then last one I want to highlight. Oh, that's super sad. Okay, I'll just say it. So what we see, so this is New Mexico, and I want to highlight New Mexico. They just legalized. All right. And they, again, went through the state legislature. And the thing to focus on in this slide is nothing. The reason this slide exists is what New Mexico legalized was the psilocybin itself, the psychedelic compound psilocybin itself, and not psilocybin analogs. And the reason I think it's important to make that distinction is psilocybin itself, mushrooms, right? They are naturally grown, but you can extract psilocybin or psilocin, which is kind of the active ingredient of it, and make that into a compound and have that as your own product that you can patent. And if you can patent it, then you can sell it. And if you sell it, it's going to be a lot more expensive, right? So think about Spravato in this one. So Spravato is intranasal ketamine. Okay, ketamine is ubiquitous. It is dirt cheap. Spravato is like $800 a spray type of thing, or at least I've heard that quoted. I've not used it, so I can't promise you that's the actual number, but it's certainly very expensive to use. And what is Spravato? Spravato is just ketamine. There's the R in enantiomer, the S in enantiomer. They separated the R and the S. They packaged the S into an intranasal spray, and that's Spravato as ketamine. Spravato. That's it, right? There's nothing magic about that. They didn't even like improve upon anything, but now it's distinct, and so it's patentable. And if it's patentable, you can charge a lot for it because you can do that. So New Mexico kind of got ahead of that, and what they've legalized is just psilocybin and not the analogs, which is a clever way to kind of start this process. Because as we start this process, there will be many different people that many different influences on this space. And so I thought this was a clever way that New Mexico approached it. So what else is coming down the pike in regards to what's in front of the FDA? So these are the phase 3 trials that are going on right now and phase 2 trials that are going on right now in regards to psilocybin. As you see, the majority of them are compounds of psilocybin. So they are these analogs of psilocybin. So these will be open for patent, which makes sense, right? This is where a lot of the research and development dollars are going to be put because these are the ones that potentially have the ability to generate revenue afterwards. And then we look at what is, what it would be used for, mostly treatment-resistant depression, major depression, and generalized anxiety disorder. This is actually a pretty cool website. If anybody wants it, just shoot me an email. I can shoot you the link. It has more than just psilocybin as well. It's got kind of everything that's from a psychedelic space that's moving through the FDA's like clinical trial or on their pipeline. So now I want to talk about kind of what's happening here in Illinois. And in that regard, I have invited, and I'm so gracious that she decided to join Representative Theresa Mah. So Theresa Mah, she represents the 24th House District. That's here in Chicago. That's kind of a lot of our neighbors here on the South Side. So she made history in 2016 when she was the first Asian American elected to the Illinois General Assembly. And as a former college professor, PhD, she actually started her graduate studies here at the University of Chicago more than 30 years ago. So welcome to your academic home, Representative Mah. Thank you so much for being here. And so the next part of this session is going to just be kind of a touch of a conversation between myself and Representative Mah. And of course, y'all are very, 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 I hope that you will include yourselves in this conversation so we can talk. So come on up. So thank you for coming. Really, really, really appreciate it.
My pleasure. Thank you.
Good stuff. Sorry, can people hear when she speaks on the mic as well? All right, good stuff. So I guess I'll ask you first, like, what kind of got you interested in this space?
Well, it's a little bit of a longer story. I have always been interested in alternative modalities for healthcare. I serve on the healthcare licensing committee, and I was chair of that for a couple of years. And so, I had some experience, being a champion for, renewing the practice act or the licensure for acupuncture and naturopathy and things like that. So, I did have an interest in approaches that are not necessarily mainstream, or didn't start as very mainstream. And one of my colleagues in the Senate presented, or brought forth legislation um, to decriminalize, and so it was much broader attempt to make psilocybin available. And I was supportive of that, especially after we had a um, we had a town hall or a panel discussion at a VFW hall in my district, and it was very well attended, and there were so many um, testimonies from average community members about the need for something to help with their PTSD and other issues, and there were testimonials from folks who had tried it, and so that really got my attention, because hearing the firsthand stories really make a difference. And learning about the work of the Psychedelic Society and their efforts to move this effort forward in Illinois, it got me interested. And so I signed on as a co-sponsor of that initial piece of legislation. And then when that didn't make it past the finish line, and there seemed to be some, bigger roadblocks to broad decriminalization, we came up with this approach, which is my bill, to uh, uh, propose a pilot project. So a smaller, more limited effort that might have an easier time getting through the legislature, and sort of opening the door for more work in the future.
Yeah, so I guess, would you mind fleshing out a little bit, kind of what is that pilot project? Is that psilocybin specific? Is it psychedelic specific, or is it kind of even more narrow?
I Yeah, so I think, yeah, so the bill that I had, and I have to sort of jog my memory, because this is already almost a year ago, right? Um, it is psilocybin specific, and we would have to get approval from IDFPR, our Department of Professional and Financial and Professional Regulation, as well as agriculture, to get their buy-in, because they were involved in some part of the process to regulate and
And so do you feel like I mean, of course, the first one didn't make it through. So do you feel like there is like a smoldering appetite for this among the legislature, or do we feel like there's pretty firm roadblocks and we're going to have to figure out a way around?
so with the pilot project, because already I'm hearing from a lot of my colleagues, especially those who've been working, in the mental health space, and trying to bring about more accessible and affordable therapies to help people around the state. And so there's interest in having discussions to figure out how to get beyond these roadblocks. And as I said, it's sort of a pilot project as opposed to the broader decentralization. And we also have a long history of having worked on medical cannabis, right? So we have some of the infrastructure, within our state agencies to address regulation of substances, and we have this track record, right? So there's, in a sense, a model, right? But we have to, get the state agencies to agree to, figure out, how do we make it for this other substance, and there might be budgetary issues, right? Hiring folks that could specifically.
Yeah, I mean, certainly when you look at kind of the rollout in Oregon, Colorado, I guess Oregon to speak to more, the budgeting issues are real. So some colleagues that work out there, it costs a practitioner $2,000 a year to be a licensed psilocybin practitioner out there. And so like, maybe if you're an anesthesiologist or an MD, like maybe you can handle that. But a lot of these folks are social workers that kind of want to be a part of their patient's care. And so that structure is, I agree, vitally important.
Perspective, that actually, it holds some promise for, a new source of revenue that could come in, as a result of the regulatory process. But, the startup costs of figuring out the needed vision, this agency that we hire people who, in addition to the folks who already work on, say, is it a resource to already have that, that agency, that regulatory process in place, or is it something where it's entirely different, sort of built in from scratch? So having the organ model is actually helpful because we can see, what's happened in another state and how much it has cost them. And so some of those figures have, been helpful for us to make that piece with our state. Let them know that, okay, after an initial outlay, we will be essentially, dealing with a self-funded process. And so, I think that there's hope, and I'm prepared to have those conversations as we move into the next session of the General Assembly. So, we return to sort of go through our work for the next session, starting in January. And so typically our regular sessions run from mid-January to first. And so, we'll be starting again with this process, and hopefully everyone part of the process.
Yeah, I feel like as I've kind of run it up the chain of command here at U of C, the thing I've been like trying to champion is like potential savings, right? Like if you help people that they might not necessarily need as much support from the inpatient side, since I'm a hospital doc, especially from like a substance use perspective. It turns out money saved doesn't go very far when you're talking with people. At least that's what I was told. So I agree. It seems like streams of revenue, and we'll see where that pops up. I got a couple of questions for Rep Mah, but like, are there any questions from the audience as far as the talk for Rep Mah or anything like that? Yeah.
I do some work for the Poison Center. I'm just curious, for this law or for this proposed legislation, are we talking about mushroom product or are we talking about?
I think that I'm not actually sure, but I mean, a lot of those things are still, open to discussion. I would have to rely on your expertise to figure out, what's the most doable.
Yeah, I mean, I think it's a great question, right? I think kind of what New Mexico did, I kind of explained why I think it's a good thing. But of course, there is a comfort with having a analog that you know exactly how much it is, and it's produced in a way that you know exactly what it is, and so you feel confident that it's going to do exactly what it was going to do. I mean, of course, everyone's experience is different, but there's a confidence there.
I think they have this notion that it would provide more equity to have the plan itself, right? Because that makes it more acceptable to folks who want to grow and have a grow license. But yeah, I mean, the language of the bill can always change depending on what means what's most realistic in terms of moving forward and, what gets the most support.
What do you think from a toxicology perspective?
I know a lot of comparisons to cannabis, medical cannabis, where it's plant-based product. The doses we've seen since the 70s grown exponentially.
Yeah.
And most of the studies for psilocybin pretty dose regularly, 27 per day. Plant-based products or mushroom-based products.
Right.
So I do worry about inadvertent overdose or using it in patients that really haven't been studied because we don't.
Yeah, and so when you look at this New Mexico, the rest of that slide, there is, I mean, it takes there are regulations for being a grower, for being an owner, for being a provider of it. And so while it is the mushroom that is being legalized, it's not anybody can grow the mushroom on themselves and use it in a clinical way. There's likely a decomparison bit, so that way under a certain number you can grow it yourself. I actually don't want to speak specifically to that, but to use it in kind of a larger format, it would be somebody who has to be part of it, be regulated, be observed, be monitored, so that way you're getting a consistent product, which is, a way to do it, right? I mean, we're right, so.
But more infrastructure.
Absolutely.
Testing,
Yeah, that will be a balance.
so all those things are still being hammered out.
Sure, Brian, sorry.
No, I'm interested in sort of the individual experience that someone taking this would have as it relates to sort of decreasing anxiety and depression. What's the thought behind how that experience does that in the sense of the experience itself and what they may visualize or go through, or is there an actual biochemical change in the brain that actually happens to cause that decrease? And what are the experiences that?
Sure. So mechanism of action, I don't think anybody can really speak to that. The pharmacokinetics are serotonin, it floods the system. And so you can see, and so they've done these studies in mice that with mice that have received psilocybin, or really kind of any of the serotonergic psychedelics, I think LSD is actually the most common one they use, that you will see actual dendritic growth of along the within the brain. And so by that I mean you can create new synapses and potentially new opportunities for connections that could maybe, now we're going to kind of get into a little bit of the story, right? But get you out of the rut. So whatever comes to you and traditionally makes you feel depressed, or post-traumatic stress disorder make you feel anxious, right? Now all of a sudden there's potentially a new pathway within the brain that could be followed. And by that kind of there's this phrase of those neurons that fire together, wire together, right? And so if this is something that's really been ingrained, you've had this for years, decades, this is going to be the normal pathway of the brain. And kind of during these experiences, what you see is kind of a evening of the playing field. By that I mean those neurons that the neurons that are wired together aren't necessarily the ones that are going to fire while you're in the middle of this experience. And so, this is kind of, again, a story way of telling it, but the idea is you walk up to let's say a path, but it's a path within tall grass. And there's this one path that is just incredibly well groomed. It's practically paved because this is what you've done, right? It's your rut, if you will. And that's just the experiences come in, it's put you here, and then the brain is going to fire this way. And during the experience, this grass goes away. And now all of a sudden you can walk in any direction. And can you create a new synapse? And can you create a new pathway that'll allow you to approach the same situation and follow a different path? Now, at the end of the experience, that grass regrows, right? And so the hard work comes in maintaining that new path and a meditative practice and the integration, and they call the chop wood, carry water part of this, right? This is not magic. This is an opportunity to potentially generate a new pathway around. So Kind of the mechanism, again, it's going to be challenging, but the best way I've seen it is like new dendritic growth, potential new routes for kind of other neural pathways, and then potentially just a new perspective on a old, or I guess a tried and true experience.
And that's consistent with what you're saying about getting out of the rut, and my understanding, of depression, for example, a lot of people don't see their way out of, hole that they're in, and so, having this reset allows them to see the way out.
Yeah, I mean, I think as far as contraindications to psilocybin, there aren't technically that many. It's like you can't really overdose on it, which is great. You could do too many and have a terrible experience for sure. Schizophrenia is a kind of a contraindication at this time. I think there are a lot of folks that would say, you could induce a psychotic break or a schizophrenic break. And so at this time, I don't think anybody would feel comfortable using this medicine with anybody who has a proclivity for schizophrenia or maybe even kind of a family history of it. I think certainly one drawback is it might not work, right? I mean, it's not going to work for everyone. It's going to be a lot of effort, a lot of time. And so that is the case. It doesn't necessarily mean it's not worth it to try. I think a lot of like the bad trips and the scary stuff you hear about is often when it's done outside of a controlled setting. So there's kind of this mantra in the space now called like set and setting. So like mindset and actual physical setting, like doing it in a space with two practitioners that can be there to support you and kind of preparing yourself for it, getting in the mindset for it, kind of really reduces these kind of bad trips, or I guess challenging trips is the way I like to describe now. But as far as like, what are some like physical drawbacks from it? I mean, it's not that many. It's a non-addictive substance. You really shouldn't be using it that much. I think if you're using it more than like 3 or 4 times a year, it's like time to press pause and say, why is this not working? Should we be trying something else? I think there are certainly reports of people kind of having like these flashback hallucinations and like of things. It's not as it's certainly very, very, very rare, but it has been written about, so it's certainly something that should be kind of discussed with the patient as they go in. I don't think those necessarily would outweigh the potential benefits, but those are really the kind of the big ones that have come across.
My colleagues' perspective, those who maybe hesitate to jump on to legislation that would either create a project or state level, they point to the fact that it's still federally illicit and not FDA approved. There's concern about, how do you, once it's available or criminalized at the state level, how do you, keep it within a controlled setting? Because there are risks that it's not, and then, the cost is pretty big.
Interesting to go back to those patients or the study participants in the confidence study a couple of years down the road.
Yeah.
What did you think? Was it worth doing? Do you still feel the effects? And for those who maybe didn't, who were the outliers of the dramatic improvement, sort of why did you get that out of the work?
Yeah, that's fair. I mean, they might all be dead, right? This is a patient population that had, terminal cancer, right? And I think one thing that is important to highlight as well, right? This is not treating the cancer, right? All of these patients still had cancer. Some of the drop off in the 56 to 51 were people who died. And so I kind of like to think of it as like for me, or I guess with the diagnosis of cancer, or a family member's diagnosis of cancer, can come this, kind of like use a gesture to describe it, like diagnosis of cancer. And it can be your whole life. It can be just in the way of everything. And so could psilocybin help kind of move it from here to here, with the idea that it's still a part of your life. You're still going to your oncologist, you're still getting lab draws, you're still dealing with whatever the treatment is that is prescribed, but you have the ability to see your loved ones, you have the ability to do hobbies that you did, right? And this is not gonna cure cancer. It's just gonna hopefully help people live with cancer. But yes, I think it would be fascinating to see, is it still durable? And then, because definitely without a doubt, there are some people that are like, that didn't do anything.
And you think as you expand, I'm so sorry, but as you expand into like, you know, like generalized anxiety and that major depressive disorder, there's so many more people in positive ways to be, you know, all
For sure. Micah.
Shmuck, great job. Following up just a little bit on Megan, what adverse events were reported in these trials?
So
why did they not use a usual or standard care arm? And maybe you could even address both of those. Quick summary of what's the deal with the FDA. So is it biologic mechanism, efficacy, adverse events, what trial design? What was
well, I certainly don't want to speak with the FDA for the FDA. The MDMA trial, there were actually some like ethical things that happened during the trial that were bad. And so that put a hamper on that. I don't know if that was the final thing, but it wasn't good. As far as adverse effects, I mean, like, so the adverse effects, when you look at the 1,500 patients that have been used in the first quarter of, that had used psilocybin in the first quarter in Oregon, there were 3. All of them were minimal. A lot of the adverse effects within the study are discussed as like transient increase in blood pressure, transient increase in heart rate that all come down to like normal afterwards. There's none within these studies that are like long term. So it seems like adverse effects can certainly exist, but they really are mitigated if you do it in a controlled setting with somebody who kind of knows what they're doing and knows what they're getting into. So it's certainly, compared to the vast majority of medications we use, it's on par, if not a lot safer. So you mean like as far as they did the low dose psilocybin versus that? So
what doctors are usually doing right now?
yeah.
You know, it's great that it showed efficacy in high and low dose, but we don't know what would happen in a placebo or standard care.
Yeah, there are definitely
saying whether or not that's real or not.
Yeah, so I think there are studies that use it just like Benadryl as another option, right? And it's like, okay. I think there is kind of an expectancy bias that people like, they want to be a part of it, so they want to really get a sense of like, okay, is it just that you're using psilocybin and like there's something magical about psilocybin? Is it dose dependent? And so they kind of want to use the control trial of like, look, there is something impressive about the dose, therefore we know it's the medicine that's doing it. Because there definitely are a number of studies in the literature that have gone kind of both ways on that. And it seems like dose dependent is the one that, for whatever reason, the FDA seem happiest about. But yeah, I mean, it's definitely a valid critique, and there's many more studies that are ongoing, but we'll see how they go.
Recognizing that we're at time.
Oh, sure.
Thank you, everyone. Next week is going to be term towards after palliative care, and I'll take responsibility for that new Mexico slide because there were some mushrooms on the sandwiches. Really creepy. See you next week.
Thank you.